All right, well, good afternoon, everyone, and welcome to our first Value-Based Payment 101 education series. The webinar that you see is a collaboration among two of our PPSs for the district program here in New York State, the New York-Presbyterian Performing Provider System, as well as the New York-Presbyterian Queens. As we start the journey of value-based payment, what we recognize is that we have a number of providers that are overlapping among our PPSs. And we do want to be mindful of your time and try to be as efficient and as effective as possible with your time to ensure to help the state get to their goals of value-based payment. And so the first few series of education are going to be some fundamental building blocks for value-based. And as PPSs, our commitment is to help our network partners move towards value-based payment by providing this education, while at the same time being a resource for both data and or educational materials or connectivity to the state. And so the webinar that we have this afternoon is going to lay that foundation, as well as really focused on some specifics as to what the state is trying to achieve. And we have categories of expectation as we roll through value-based payment that the state has asked every PPS to achieve. So we have to have a number of educational sessions for primary care providers, for behavioral health providers, and for community-based organizations. And so as we begin down the lovely journey of VBP, we wanted to ensure to set the platform for the first initial outreach and do some 101 series as to, what is value-based payment, why are we doing it, and kind of where the road is leading us. And so today we're going to cover in the next hour a number of things. We're going to walk through why are we doing value-based payment, what are the options, who is affected, and then talk through with our partners on becoming ready for value-based payment to do a readiness assessment and planning, and then also talk through what are your resources, what other opportunities will you have to do education, and then from a PPS perspective, how do we ensure helping you move forward. So speaking as Amanda Simmons, as I mentioned, and we have a number of PPS representatives that are on, and so in the what we are going to ask is that questions, if you have them, if you can wait till the end, and we will do a question and answer session if there's time, and we will try to address things. And then there are future educational series. For example, January 30th is the second education that we're doing. We will focus on the 30th to the value-based payment roadmap. And the roadmap is a state document that kind of walks us through the state expectations of how we're going to move towards value-based payment. And so that's another opportunity for questions and answers, as well as we have our contact information loaded in this document that we will share, so that if you have any questions at any point, we are here as your resource. So. All right, diving right in, being mindful of time. So to paint the picture of why value-based payment is so important. And so value-based payments, you'll hear it termed as many things depending on what part of the country you're in. So value-based, alternative payment methodologies, and the reason value-based is so important. I've got feedback on someone's line, is that as health expenses across the nation are continuing to grow on a per capita basis. So you'll notice in the slide that you see there are a number of increases to our healthcare costs across the nation, and we're running about $16,000 per capita in projected of 2025. And so as the population ages, as the population increases, our per capita spend is increasing as compared to, let's say, 2014, when you're in the, the high 9,000 per capita. And so increase of cost is one. Sorry about that, my screen froze up on me. As the cost increase across the nation, what we're seeing is that there are driving chronic conditions that are driving those costs. So, you know, you see increased stroke, heart attack, cardiovascular disease, diabetes, hypertension, and you see the same progression. So as 2025 comes upon us, those disease profiles are getting more and more prevalent in our population due to numerous things. And so your cost is increasing, your disease rates are increasing, and so value-based payment is one method to allow that not necessarily does it decrease costs overall, but it's a slow progression of trending and to decrease over time. So from a national perspective, we're seeing this, as well as from a New York State perspective. So the burning platform for the state is similar to that of the nation in that the projected spend is increased when you look out over a few years. So by 2020, they're projecting to spend about $318 billion. And so, again, paying close attention to that per member per capita rate is important for the state. New York State is a Medicaid expansion state, as you guys are well aware. And so as we enroll additional Medicaid patients, you'll see the trend of majority of patients are going into Medicaid managed care programs, which is a much stronger engine in order to manage cost and to manage value-based payment activity. And so 2013, 2014, about 76% of the activity is enrolled in managed care. And then there's a few other items on here that, you know, just are important to the state as we look through alternative or value-based payment methodologies. And so the fact that 31% of New York State population is low income is important, as well as you're seeing trends grow in the New York market. And so obesity, poor mental status, diabetes are three of those that align with that national burning platform from a disease profile perspective. And so, you know, when you take a step back and kind of say, okay, the trend is that cost is growing per member, disease profiles and chronic conditions are getting worse. So how does value-based payment or VBP help from a sustainability planning method? So with VBP, the goals of this initiative are to decrease the total cost of patient care while improving patient quality outcomes, increasing access to things like preventative medicine, and just simple access to care, increase the patient engagement and accountability, and then also increase the provider engagement and accountability. So there's a communication among both sides in regards to the patient's health. And then overall, the goal is to decrease both federal and local spend on, you know, in this situation, the Medicaid population. And so value-based payment is not just a Medicaid initiative. This initiative is across multi-payers. Medicare has been doing it for quite some time, and there's all kinds of other acronyms for Medicare, such as MACRA and MIPS, and, you know, in healthcare we tend to like to talk in acronyms. And so the initiative is consistent across the nation, across multi-payers. So what exactly is value-based payment? So value-based payment is moving from where providers are incentivized by quantity of visits to quality, and moving from a fee-for-service environment to a risk-based method of payment. So we're shifting the risk from the managed care payers down to the providers and the patients, and or sharing risk. So you'll hear them termed as risk sharing or other types, and in just a moment we'll walk through a number of those. Again, it's intended to decrease the healthcare costs and build shared saving models between managed care organizations and provider groups. There are multiple levels of value-based payment that we're going to get into in just a second. And as I mentioned, VBP includes many payers, Medicare, managed Medicaid, and traditional managed care as well. So with VBP, the encouraging part of this is so that providers can collaborate among their network of partners and or providers and also engage that patient to be accountable for their quality of care as well. So previous world has been fee-for-service, and so fee-for-service, this is your quantity. You're reimbursed on a per CPT or DRG, and there's no reimbursement for things like care coordination. There's very little accountability for provider outcomes, and there's also very little conversation around health disparities and items that are not necessarily a reportable item that kind of brings us into the community-based organization side of things. Moving forward into value-based, this is where you move from quantity to quality. So you're incentivizing quality-based outcomes. You're aligning the right care in the right setting. You're integrating delivery among a network and or a community. As I mentioned, you've got that provider and patient engagement among, partnering together to collaborate the care. You're encouraging providers to use health exchanges to ensure coordination of care. There are levels of risk models based on a risk-based assessment that, depending on what the provider is willing to assume as from a risk perspective. And then you have the ability to align multiple payers within value-based payment to ensure that your clinical care is consistent among multiple payers. So when you think of today's fee-for-service, so moving from left to right on the screen you see, you have fee-for-service, you have pay-for-performance, which is where you begin to get into value-based payments, but it's on the side of just specific pay-for-performance, very little lower risk and all upper risk. Episodes of care, which you're paying for episodes of care. You move on to shared savings programs, shared risks, and then finally the end of value-based payment is the capitation model, which is you are being reimbursed on a capitation per patient perspective. Within Medicaid, there are multiple levels of VBP. So level 0, which is the current fee-for-service, level 1, which is fee-for-service, and then upside only, which upside meaning that there's risk or there's gain on the fact if you were improving. Level 2 is a fee-for-service with the risk sharing, so you've got some upside and some downside. And level 3 is, that, as I mentioned, that capitation. And the reason we lay this out is your levels of alternative payment models are different between Medicare and Medicaid, and it is all dependent on your conversation with your payers and, again, how aggressive or risk-averse the organization is. In one of our trainings, we will go through the roadmap, as I mentioned, and that roadmap will outline the state's expectations of what percentage of our managed care payments are in which levels. And so again, as we're kind of laying the foundation of education, we want to ensure that we talk in the right, with the right terms so that we're all on the same page. All right, so with that as the basics, what are our options for VBP? And so value-based is somewhat prescriptive in the sense that within the state of New York, they have given us options on how to build VBP arrangements. So the first option comes as what they call total care for general populations. So this is where total care for all attributed lives and the attribution of lives is defaulted by the primary care physician. And so you're taking on responsibility for the care of the attributed lives within your network for all of their activity regarding healthcare. The only exclusions you have for this population are those high-cost items such as transplants, specialty medications, subpopulations of HIV and AIDS, your HARP, which are your health and recovery plans, your managed long-term care patients, and your intellectual developmentally disabled patients. And the reason the state excludes those is the latter three that I mentioned, HARP, MLTC, and IDD, all have New York State specific managed care kind of style organizations that are managing the care of these populations. And so for total care populations, again, in those levels, you have levels 0 through 3. And so walking through your level 0, remember, is just fee-for-service. And there are some options for bonuses based on predefined metrics. But it's very similar. It's basically what's happening today. Level 1 is when you move to upside only, and level 2 is upside and downside, and level 3 is capitation. So in a general care population, what you would do is you would assume risk if you were going into level 2, for example, of upside and downside. You would assume risk for this population for their entire care, for all conditions. So there are many different varieties of how you contract with the managed care organization for this, but, having, for example, a per member per month reimbursement, and then having quality indicators to kind of gauge performance is one way to do that. And there's multiple other ways. What we as a PPS have to be mindful of is that as we're educating our network, both the New York-Presbyterian and the New York-Presbyterian Queens PPSs are not, we're not an official incorporated entity, and so we are not allowed to give contracting advice. And so what we'll do is, as we walk through these things, we'll give you examples, and then we encourage you to either reach out to your internal managed care organization representatives or your actual MCOs to begin talking through contractual language. So the second are what they call integrated primary care bundles. So integrated primary care bundles are items such as PCMH or other primary care initiatives. They really focus to preventative medicine, the sick and the chronic conditions. They, again, are attributed lives by PCP, and then that same subpopulation exclusions. And then you're allowed, as similar to PCMH, you choose episodes based on your patient attribution. So the episodes that are approved for the Medicaid VBP are those that are listed. Things like preventative care, asthma, hypertension, diabetes. And you'll notice the items that are listed on the episodes that are included are also the items that are increasing cost across the nation. So again, aligning strategies of multi-payers, you'll see most payers will pick your top diabetes, asthma, hypertension, COPD as your inclusions, because what they're trying to do is to get a handle on the cost of care for this patient population. And it's been proven items such as PCMH do a very good job at maintaining costs for such disease profiles, as well as the care coordination aspect are tremendously helpful for such disease profiles. So again, I won't go through every one of these because I know that I don't want to put everyone to sleep on such a riveting topic, but it gives you an idea of how levels 0 through 3 walk through specifically for the integrated primary cares, which is very similar to that of the general population we just discussed. The third is a maternity bundle. So understanding that pregnancy is one item that you can bundle together to try to encourage quality of care as well as quality outcomes for both mom and baby. So the pregnancy, the delivery, post-delivery, and the first month of the newborn care are typically included in the maternity bundle. There are items within this opportunity that you can do that are called stop-loss protections, just so that if a baby and or mom are dubbed as high risk or go into the NICU, that there are stop-loss protections that the providers don't hold all of the risk, understanding that, you know, what you may see as a normal pregnancy in months 1 through 3 may drastically change in the latter months. And so those stop-loss protections are important for maternity bundles. This one's slightly different, to where we attribute members based on the OB provider, which in many cases might be the primary care provider, in many cases might not. And once again, those same exclusions are for this bundle to ensure just maintaining the costs within the population. So the level 0 through 3 are listed, and the maternity bundle is probably one of the simplest bundles, just because it's a contained encounter, right? And to where patients are pregnant, they deliver, there's the baby, and you can report and contain all of the cost of that. There's encouragement for quality on things like vag delivery versus C-section, and multiple things that managed care organizations will work with the providers in order to keep the cost down specific to maternity. All right, and then the total care for special needs population. So this one aligns with those 4 items that I mentioned earlier that have been excluded from all the other bundle opportunities, or all the other VBP opportunities. So as I mentioned, the state has already aligned managed care arrangements for subpopulations of HIV and AIDS, or long-term care, or IDD. And so their MCO breakdown is specific for these patients. Members within these organizations cannot be assigned to multiple populations, so the MCO gets to designate which one it falls into if they are eligible for multiple. But you can combine value-based payment arrangements for multiple of these subpopulations. And then the member attribution is based depending on the type. So for example, on HIV and AIDS, they assign it by primary care provider. For HARP, they assign it as from a medical home. Long-term care, it's facility and or primary care provider. And then the IDD is either primary care or the assigned behavioral health provider. So once again, you have levels 0 through 3, depending on the type of arrangement, level 0 being current, level 3 being the capitation, which is a capitation model based on those 4 populations. All right, so that is the kind of groundwork of what New York State has identified as allowable VBP options within the Medicaid population. So, you know, now that we know what it is, what we want to look at is, you know, who's affected by value-based payment. So a value-based contractor, to use the word loosely, can be many things. So it can be an entity that contracts with a managed care organization, a hospital and or others. It can be an accountable care organization. It can be what they call an independent practice association, an IPA, or it can be an individual provider. So one of the things that we have to keep in mind is that you do not have to be a part of a very large, you know, network of providers to enter into value-based payment agreements with managed care organizations. There are perks to probably every angle of argument there, but as an individual provider, you can choose to enter into these agreements based on your own strategy and our own patient population, and depending on what kind of provider. So the providers, of course, primary care, specialty care, behavioral health, and then facilities. And in many markets with VBP, what happens is they form a network of some type to be able to contract with the managed care organizations. And the reason they do that is there's leverage in size and number of providers, attributed lives that you bring. So you have more negotiating power sometimes, but that doesn't mean that an individual provider can't have the same. It's just, it's where the strategy lies from a provider's perspective. Now, within the contracting types of an ACO or an IPA, there are expectations and regulations that you have to abide by because those are defined entities that both the state and the federal government watch very closely. The good things about those, you know, for example, an ACO, is that you have that continuum of care typically covered for the patients. And then you have the collaboration as well as a lot of the data exchange and the IT side that you have to discuss among network and partners. And then you build that continuum of care that makes a strong quality outcome for the patients. Excluded providers, this is important because any provider that is financially challenged, which financially challenged, the term is actually defined by the Department of Health by having less than 15 days of cash on hand, no assets other than your operational assets, and that you've exhausted all efforts to obtain resources from a corporate parent and or other affiliated entities, means that you are financially challenged and that the state would give exceptions to moving towards value-based payment activity, because obviously if you're financially challenged, you cannot take on risk as a provider group. The one thing to remember is if you're going down the road of being, quote, financially challenged and dubbed that way by the state, is the state has defined that if you are, then there's a planning process in place with 3 items: either to be absorbed under the umbrella of another health system, be transitioned to another license or service line, or to discontinue operations. So as they do this, they want to, you know, help ensure that there's a plan of becoming financially stable depending on the organization. So, and they've outlined that financially challenged organizations cannot enter into VBP arrangements of level 2 or higher. So I'm going to kind of gloss over the timeline here because a lot of this material is going to be covered in our roadmap webinar on the 30th. But just to be mindful that the state of New York has outlined specific goals by year to ensure that they meet state expectations for value-based payment engagement. So our goal by the end of DY5, which is 2020, they have 80 to 90% of the managed Medicaid expenses to be assigned to a value-based payment contract. So remembering those levels, 35% of the total payments have to be in line with the level 2 or higher, and then 15% of level 2 or higher for capitation. So there is a very specific formula that the state has that will show if we achieve the goals across the state for VBP. So as all of the PPS networks are working towards this, we are keeping these timelines and expectations in mind and helping our providers to move towards this goal. So from a provider perspective, when do you know you're ready for value-based payment? What we encourage is there's a quite lengthy process of reviewing readiness and assessing your strategy and your plan. And so the document or the items we have in this document are not everything you need to do. These are just some highlighted points to help you start thinking through your readiness. And so looking at your long-term strategies as a practice and or provider. So how does VBP align with your multi-payer strategy? Looking at your risk tolerance to see from a risk-based perspective what level you feel most confident with, levels 0 through 3, remember, up to capitation. And then the feasibility from the financial perspective. So VBP is all about doing the right thing for the patient in the right setting, but we as providers have to realize that improving care and quality sometimes means decreasing revenue for our either providers and or facilities. So keeping those patients out of the emergency room is a great thing to do, but does have a financial impact on our hospitals. So going through that financial analysis to really look at, you know, the pluses and the minuses as you do this. The other is looking at your practice trends. And so who are your top payers? Remember, everything ties back to an attributed lives. So who are those managed care organizations that you should have relationships with? What are your top chronic conditions? What is your utilization of patient activity? So where are your patients going? Who's in your network when you really think of it from a patient perspective? And then which quality metrics do you feel your practice can report on, and how do you do within those quality metrics? So kind of really looking at that baseline of quality and assessing compared to either state or national benchmarks to see how well are we doing. Also looking at your information technology capabilities, you know, what pop health tools do you have? Do you have a robust electronic health record that will be able to track such things as quality metrics? And then the Rio connectivity, because remember, when you go into VBP, you're accountable for the patient, and you want to ensure that there's communication across the continuum of care for that patient. And then next would be looking at your value to networks. And so as I mentioned earlier, what are your quality outcomes? What do they look like? What members do you have by payer? What's your volume that you bring? And then what is your market share? So currently, within your current practice, where do you have the strongest market share, excuse me, for the patients? And so in many ways, the provider value for VBP is very, I wouldn't say it's the most important, but it's very important, and here's why. So if you as a provider can understand the value you're bringing to either an MCO or a network, be it an IPA or an ACO, you have a stronger negotiation seat so that you know your value. And so if you go in blind, not knowing how you're doing on quality or what your market share is, there's very little opportunity for you to really show either the MCO or the ACO the value you bring to the table. All of our providers within a network bring some form of value just depending on where their seat is on the bus. So that's important. And then finally, the community needs assessment. So as I mentioned earlier, you're looking at your patient base, but also kind of take a step back and look outside of your patient world to see what are the demographics and disease profiles of the community, because your practice may change, and I should say will change based on the dynamics of the community you serve. What is your potential to impact that community from a practice perspective? How have you or have you not had engagement with community-based organizations that could help you from a quality perspective? And then what are those existing ACO and IPA networks that are out there so that you're aware going in to know what either your competition is or what networks you could join, depending on if the strategies align. So what we tell everyone that's very important is that payment reform, value-based payment, should never outpace care redesign. And what we mean by that is that we could go and negotiate these snazzy contracts that are going to be risk-based and bring all of this quality measuring and reporting, but if your clinical side of the equation is not ready and you have not begun redesign of really looking at the continuum of care for the patient, your VBP will be, it will be in vain in some ways, because what will happen is your clinical side will not be able to keep up with your reform side, and so your access to care, for example, or your quality outcomes for a specific metric will will not be as positive because the clinical side is not up to par. So just keep that in mind and keep the two in line to where as you're discussing and thinking through VBP, you're already looking ahead on the clinical side to say, okay, you know, do we have improvement opportunities? How can we truly impact this? All right, the next item that we would like to discuss are what are the resources? So as a PPS provider, there are numerous resources for you, be it at the PPS level or at the state level. And so, as I mentioned earlier, our PPS models are not formal entities. You know, we are not an ACO. We're collaborative models. And so what we have built our plan on is really outreach, education, and awareness, and then also helping the network partners with financial specific data elements that we have and have access through the district program. And so there will be a number of educational opportunities that we will communicate out to our PPS providers, such as today or January 30th for the roadmap education. There are New York State DOH boot camps that they do that I would encourage everyone to attend. There's a VBP university that the state has created where you can actually become certified in value-based payment, and they have tests and all kinds of things that you can learn quite a bit. As I mentioned, the data side is important, and the PPSs will be a resource for you. And so that is specific to Medicaid because the only data that we have. So the only data we have is Medicaid. And then finally, you have specific subject matter expertise from the PPS that can help you. So each PPS has staff that either attend the VBP universities and things to stay abreast or have backgrounds in value-based payment and other areas that we would like to help and become a resource to our partners. As I mentioned, the VBP University and the PPSs all have websites so that if you have questions, you can go on specifically to the VBP University or our website. We're trying to be as mindful of your time as possible so that they're effective. I know everyone's just ripped out and meeting to death, so we do want to be mindful of that. So we welcome your input from an educational perspective. Excuse me. And then finally, to wrap up, because I know this is a lot of information in a very short amount of time, but specifically for behavioral health providers, because that was our focus today, to really have a forum for our behavioral health providers to, one, be educated and two, ask questions. Where do we go from here? So as behavioral health providers, one, you know, ensuring that everyone completely understands where we're going with VBP. And when I say everyone, it's not just your district people. It's also your providers. It's your leadership. Value-based payment only works if you have the buy-in from top to bottom. So if you start from the top and try to do a top-down effect to where the C-level suite all agrees with value-based payment, but it's not trickled down to Susie at the front desk, Susie will inevitably miss something, and it all trickles to VBP. So that understanding, we encourage our providers to really educate at multi-levels within their organization. And as we mentioned, we're trying to do a number of these educations to where you have access or we share documents so that you educate your staff based on your staff's needs and availability. By attending those webinars and other meetings. I've already discussed attending the boot camps. I think they've been quite successful. I've been impressed with the state's university there as well. Looking at your full practice and aligning your VBP strategies for your practice, analyzing your patient conditions, looking at your readiness for VBP, and then beginning to engage in conversations with network partners. And so deciding, as a behavioral health provider, can we go at this alone, or do we need a larger network to be able to consider risk-based arrangements for patients? And then, as I mentioned earlier, of not letting your payment reform outpace your clinical, is really taking a good look at your clinical platform to identify, do we have any gaps? Do we have needs that before we go into this that we need to address? And those needs could be from a patient perspective, it could be a provider, it could be an IT tool, just someone just coming in with a fresh eye just to say, you know, this is missing. So, for example, if you went into a value-based payment arrangement for a behavioral health provider or behavioral health patient, and the access between primary care and behavioral health was missing, that linkage, depending on your VBP agreement, of course, if that linkage is not there, your metric is at risk, because that access among primary care and behavioral health, we all know, is quite important, and or vice versa, in primary care to behavioral health or behavioral health to primary care. We did include, the state distributed at one of their universities a behavioral health value-based payment implementation kind of, I don't want to use a roadmap because that's not the right, but it's a guide to, in a quick glance as an organization, how do I know where to start, you know, looking at your governance as this is your strategy, and then kind of going through strategy and then through data, what do you have, your stakeholders and your finance, so that this is something that you can share among your organizations. You can definitely use, as it's a state tool, to be helpful for our behavioral health providers. All right, so our contact information is included for both PPSs. So at any point, as I mentioned, feel free to reach out and to email.